Welcome everyone. So today's webinar is on the malaria burden in Southeast Asia, research findings and community engagement impact. And the webinar is brought to you by the Global Health Network at the University of Oxford and OUCRU and MORU. The webinar today is 2 days before the World Malaria Day, and it aims to provide a deep insight into malaria and the often overlooked burden in Southeast Asia. So a panel from OUCRU and MORU will discuss the regional malaria research portfolio, including MORU and OUCRU's historic role in the war against malaria. So my name is Chanaki Amaratunga, and I work at the Mahidol Oxford Tropical Medicine Research Unit based in Bangkok. And I'm delighted to be joined by a distinguished panel of colleagues from MORU and OUCRU. We have over 800 participants who have registered today, and they're from over 94 countries. And to start off, I'll hand over to Professor Trudie to give opening remarks.
Thank you so much, and welcome everybody. Thank you very much for joining this really important session today. We're delighted at the Global Health Network to serve as hosts for this, and really, I think the timing is obviously vitally important to acknowledge that it is World Malaria Day on the 25th of April. And of course, the whole idea is to give this the time to bring teams together to look and focus in Southeast Asia. But I'll come on in a minute to talk about how we can extend this globally. And it's wonderful to see so many global colleagues from around the world. And it's great to see you introducing yourselves in the chat. So the Global Health Network's role is to simply convene and connect health researchers and research organizations from across the world. And in fact, this program began in East Africa from working on a malaria program where we were trying to connect everybody working on malaria drug and vaccines trials in East Africa and connect them to share resources and tools beyond that. And then here we are nearly 15 years later with a community of over 1 million researchers from across the global south, and working really hard to connect these researchers up with each other like we are today, and also with research organizations who can fund, support, sponsor, train, connect up everybody so that we can all do more and better studies in these areas where it's needed. And the whole point is trying to enable more research and equity in health research. And malaria is no better topic than that. You know, I began my career, I don't even like to say 30 years ago, working on malaria. And, you know, we've made incredible strides. You're going to hear about that today. But the truth is, here we are still dealing with this absolutely devastating disease of poverty. And it continues to cause the misery and blight that it does across the world. And so what we're going to hear from today is some incredible colleagues working in Southeast Asia. And that's going to cover the whole ecosystem of health research that's needed, and that research cycle you need to tackle any disease. So you're going to hear about working in the community, you're going to hear about epidemiology and discovering what the burden is still, right through to implementation trials and especially a focus on vaccines. So this can really help us sort of focus and shed a light on the elimination efforts through to community engagement. And really this is all around whether we can really feel that we can look at successes we're having in tackling malaria. What I really hope we get from today is lots of engagement from you all who are online today. We are recording this session and it's going to be available later on the Malaria Hub, which I'll talk about more in a second. Please post your questions in the Q&A, and those will be taken up as much as they can at the end of the call and the time that we're going to give to responding to questions and having some discussions. But those will also be captured, and we're going to extend this dialogue to keep this discussion going. And so this session today is brought to you by the Malaria Knowledge Hub on the Global Health Network. And this is quite a new initiative that is simply a response from the community to have this focus on malaria, which is so vital. And so if you have a look at the Global Health Network Malaria Hub, and I'm sure colleagues can drop the link in the chat now, so please just take a screenshot and hold on to this, the link, so you can look at it later and get involved. And you can see that there's a space to map where you are and talk about what you do. The whole point of the Knowledge Hub for Malaria is to create this neutral broker, this connecting space where that you all as researchers working on malaria can come together, highlight and explain your work, seek collaborators, make your work clear to some of the organisations you might wish to work with, and that's from the WHO to potential global partners, funders even, and to get your work seen and known, but really to knowledge exchange like we are today, to find out who's doing what, to share tools and methods and resources so that we really can create that equity in terms of where research happens, who leads, and most important of all, who benefits from the evidence and how it's taken up into policy and practice. So I'm so excited to listen to you all today. I would really hope that this session is followed by one that focuses on Africa and then Latin America, and I can see colleagues on the call from both those regions. So we throw out that invitation for you to step up and say, okay, let's do this for our regions too. And I'm sure that the following presentations are going to give us really interesting perspectives from those different areas. So please join in, post your questions. The link will be shared later, but most of all, please join the Global Health Network knowledge community for malaria, which is there as a neutral facility for you all to work together. Thanks everyone for organising today, and I'm really enjoying the chance to listen to you all and hear these updates, and I hope I can get involved later on in the discussion. So back to you, and looking forward to hearing from everybody. Thanks, everyone.
Thanks very much, Trudie. So let's get started. Our first speaker is Dr. Iqbal Elyazar, who leads the Geospatial Epidemiology Program at the Oxford University Clinical Research Unit in Indonesia, OUCRU, Indonesia. And he is trained in biostatistics and health informatics and holds a DPhil in malaria mapping from the University of Oxford. His program focuses on advancing public health research by examining the burden of infectious diseases and their underlying risk factors. And Dr. Elyazar collaborates closely with the National Malaria Control Program at the Indonesian Ministry of Health and contributes as a member of the Technical Working Group for the Global Fund Malaria projects in Indonesia. He's also an Associate Research Fellow at the University of Oxford and an Adjunct Associate Professor at Monash University, Indonesia. And I hand over to you, Dr. Iqbal.
Thank you, Chanaki. Thank you, everyone. This is the right time to pause and reflect what will happen related to malaria in the region. So I'm trying to think about whether we have a chance to win the fight against malaria. Is what we are doing achievable, or are we just hallucinating? So first, I will take you to our battlefield, our war zones. In this region, there are 22 countries, 5 of which have been declared malaria-free. Meanwhile, the other 17 countries are still struggling with the local transmission. Nearly 1.9 billion people live alongside malaria in the regions. The figure that we use today is from the last year official WHO report, indicate that there were about 5 million reported cases and 1,400 deaths over the past 3 years. These reported numbers are certainly lower than those estimated by the models. We suggest about 20.2 million cases and 30,000 deaths. In comparison, we can say that the model estimate for the cases are 4 times higher, and for the death, 21 times higher. So you can see that looking at the local case numbers, the worst hit of the battleground are PNG, Papua New Guinea, Indonesia, India, Myanmar, and the Solomon Islands. Based on the model itself, the 4 most affected countries are India, PNG, Myanmar, and Indonesia, and together they account for 97% of the total cases. When examining the type of the enemy that we are facing, it is clear that the dominant enemies are falciparum and fiver. However, the dominance of the species varies across the countries. Let's see for the 3 large countries, the main problems are both parasite, but for the other countries such as Myanmar and Cambodia, they are dominated by the vivek malaria. And looking deeper into the 4 main contributing countries, generally, the number of local cases actually increasing alongside the number of tests conducted. However, in India, last period, There is a noticeable decrease despite high testing rate, which suggests that the burden might has been decreased. But we see that there are still countries that might have a chance to eliminate malaria soon. For example, Bhutan, Malaysia, Nepal, and Vietnam, where cases are tending to decrease. But for the other countries where the 5-fact dominates, a complete treatment strategy are required and should be prioritized. In this region, in the Southeast regions and the neighboring countries, we face many challenges. This include the dominance of the two parasites, Falciparum and 5-fact, the evidence of the parasite resistant to drug, resistant to Anopheles mosquito to insecticide, the problem of relapse that still has no solutions, diagnostic that may slow density parastemia, and the access to testing and treatment. But with also concerning actually is the lack of the cross-border cooperation, as if the success of the one country to eliminate malaria will not be affected by the failure of another country in tackling malaria. So increasing the connectivity will open opportunity for the return of malaria, for example. So Plasmodium knowledge. So we are not yet done with Falciparum and the 5-fact, but Plasmodium knowledge indeed remains an obstacle for the country to claim malaria-free status. You can see that Cambodia, Indonesia, Malaysia, and Thailand. Its control involves groups that are geographically hard to reach and will continuously face interaction between the forest, mosquito, human, and the animal reservoirs. One thing is very interesting in the region. Regarding mobile and migrant population, this group will become a stumbling block for elimination for the country with the high forestry activities, such as Indonesia, Malaysia, PNG. The spatial approach is needed. For example, the approach to forest people who live constantly, permanently in the forest will be different from the miners who temporarily live in the forest and return to malaria-free areas. And our region has the hyper-endemic areas that are even higher than Africa. Almost everyone has had malaria and contracted it more than once a year. Transmission occurs through the month. Outdoor activity cannot be banned and become prime target for the mosquito attack. Geographical access is very difficult, requiring long-length transportation, and that's not yet fully safe for the health worker to enter the remote areas. Even though there's no strong evidence of parasite resistance to artemether yet, but the indication of that people who receive the full treatment completely for 3 days and return with malaria for the following months might serve as a warning to us. And of course, the further research is needed to investigate this. Yeah, these 3 mosquitoes are the primary factor in Papua. And this mosquito attack are truly extraordinary here. In some places, the number of infective mosquito bites per person per night reaches 1.5 times. You can imagine that if the person exposed for dozens of nights, the likelihood of infection will increase significantly. So we all know that the failure is clear, is imminent if we don't do better. So the graph on the left shows an estimate what will happen if the situation remains the same as it is now. The malaria elimination in 2030 will be very unlikely in the Papua region of the both countries. So we need a way to reduce the intervention that can drastically and quickly control this situation in the next 3 years, something that has never happened before. I think researchers, program managers, and funders need to sit back and review the situation again to ensure the optimal intervention for the futures. Yeah, Sri Lanka is already set an example for receive the malaria-free certification. It took several decades to ensure malaria-free status, and we learned a lot from these countries, especially in the robust surveillance system and monitoring, community engagement, and leadership, the local leadership. Unlike the greater Mekong subregions, they started with semi-higher cases in a region geographically larger than Sri Lanka. Many factors contributed to the reduction in the cases there, but the investment in fund and human resources was not small and may be difficult to replicate in Papua, for example. So for a country like Indonesia, an archipelago, the largest archipelago, it can be viewed as 5 separated a different setting, region, each with its own characteristic. For example, in Java and Bali regional, out of 128 districts, most of them are malaria-free. So at least Indonesia should achieve victory in this region first to motivate the fight against a larger enemy in other areas. So we must not be relaxed about this one. So experience shows that the experience has shown the evidence of this rebound of the malaria. So Indonesia has learned a lot from the dozen of districts that malaria-free, but later experience with malaria outbreak. The paradox of the success were the success in clearing area for malaria lead to the decreased attention and resources, and has proven to be troublesome for us. I think as with today's theme, I think the war against malaria will be becoming difficult. Research funding is significantly reduced. Donor organization will not last long, exhausted, tired, and the loss of institutional MORU will make this a long war. So indeed, it's a time to reflect the current condition. Thank you. Back to you, Chanaki.
Thanks very much, Iqbal. So we'll take questions at the end of all 4 talks, and we'll move on to the next presentation. And this will be by Professor Arjen Dondorp. So Professor Arjen Dondorp is an infectious diseases and intensive care physician based at the Mahidol Oxford Tropical Medicine Research Unit in Bangkok, Thailand, where he is the Deputy Director and heads the Malaria and Critical Illness Research Department. He is a Professor of Tropical Medicine at the University of Oxford, a Professor of Translational Global Health at the University of Amsterdam, Visiting Professor of Clinical Tropical Medicine at Mahidol University in Thailand, a Fellow at the Amsterdam Institute of Global Health and Development, and a Fellow of the Academy of Medical Sciences in the UK. And over to you, Arjen.
Thank you very much for this nice invitation to give this talk. So I will focus on falciparum malaria because I was thinking that Kevin Baird in the next talk will probably talk a lot about vivax malaria. So the subregion, historically the cradle of antimalarial drug resistance. So chloroquine resistance started here, but also sulfadoxine pyrimethamine resistance started here and then spread over the rest of the tropical world. And the latest one was artemisinin resistance in the early 2000s. So artemisinin resistance in falciparum malaria is not full resistance. It's mainly the ring stage that become much less susceptible to the drug, but that has big consequences in how quickly the parasite is cleared from the circulation. So instead of a parasite clearance half-life of around 3 hours, it goes up to 6-7 hours. And because we give this drug as an artemisinin-based combination therapy, where the artemisinin component has a very short plasma half-life, after 3 days in sensitive infections, you are only left with 100 or 1,000 parasites in the blood. But in resistant infections, this can be 1,000 to 10,000 times more. So then they have to be cleared by a monotherapy partner drug, and that facilitates also development of resistance to the partner drug. And that's what we have observed in the Greater Mekong subregion. It started with artemisinin resistance, but then also mefloquine resistance increased dramatically on the Thai-Myanmar border. Piperacin resistance emerged in Cambodia and spread quickly there. And then we got high treatment failure of the ACTs, which is of course very worrying because artemisinin-based combination therapy are the only real good drug we have at the moment to treat falciparum malaria. So this was recognized by everyone as a real important threat for the treatment of malaria in the Great Mekong subregion, and with that fear that it could spread to the rest of the tropical world. It was also recognized that if you want to get rid of artemisinin resistance, you have to get rid of all falciparum malaria, because with persisting drug pressure, the last remaining parasites will also be the most resistant one. So getting rid of resistance means trying to eliminate falciparum malaria from the Greater Mekong subregion. And this was embraced by both at the political level, recognized by the WHO early on, and by other stakeholders. And plans were being made, but the big game changer was the Global Fund RAI, the Regional Artemisinin Resistance Initiative, which was a multi-country grant with a strong regional collaboration between the 5 countries, steered by a regional steering committee where all the different stakeholders were working together and being represented. So the National Malaria Control Programs, the civil society organization, the NGOs, there was engagement with the private sector, the WHO was strongly involved, academia was there, APOMA, an organization in Asia focusing on malaria, and various other ones. And there was a lot of money available from the Global Fund until today. We are now in the 4th round of these 4-yearly grants from the Global Fund, and almost more than $700 million has been spent on malaria elimination in the region. And that's by far the largest chunk of money available for malaria control and elimination here in the region. So it has been very successful, this program, and because of this very good collaboration between all the different stakeholders in a regional matter, but also because of this implementation structure of village malaria workers in all the communities that have malaria present. And this is really an architecture that can also be translated to other countries in the world as a very effective implementation structure to get rid of malaria. And here you see 2 examples, both from falciparum and vivax malaria, where a high quality village malaria worker network is able to reduce malaria very rapidly through early diagnosis of symptomatic cases and treatment with an effective antimalarial. And this is an example from Myanmar, where MAM, which stands for Medical Action Myanmar, has been implementing these programs in a large network of community health workers. When malaria is going down to very low levels, it's important that the malaria workers do not only look at malaria, but also to other health problems to ensure continued uptake of their services. And this has been trialed in different settings in the Greater Mekong subregion. Here's an example from Myanmar, where they showed that with malaria going down, the uptake of the services was going down until they introduced an extended package where the village malaria workers were now community health workers, also looking at respiratory tract infection, diarrhea, acute malnutrition, and could refer cases of tuberculosis or severe illness. And with that, the uptake of the services increased dramatically again. And with that approach, they were able to eliminate malaria in a big part of Myanmar. So the village malaria workers network with early diagnosis and treatment, also, by the way, bed nets were being used, but they are a bit less effective in this part of the world because of the early biting behavior of the prevalent Anopheles mosquitoes. This is really the pivotal cornerstone of the malaria elimination effort, but they are supplemented with specific elimination measures to get rid of the tail end of the parasites. And one of them is mass drug administration, which has been trialed by our unit. This is an example of DHA piperacin in several countries in the GMS, looking at the prevalence of malaria was looked at in surveys where everyone got a blood sample with a very sensitive PCR technique, and that could show that MDA was able to really get down to very low levels of Plasmodium falciparum prevalence compared to the control villages. But these were quite isolated villages. So over time, then malaria creeps in again, and malaria is increasing again. So it has to be supplemented with this very effective global village malaria workers, not global, village malaria community health workers networks, to keep on surveillance and keep treating cases of malaria. And this is an example from the Thai Myanmar border, led by SMRU, who set up a malaria elimination task force. They had a big problem of artemether resistance and failure of artesunate mefloquine. They started this focal MDA approaches with DHA piperacin in their networks of village malaria workers. And as you can see in the maps there on the right side, they were able to bring down falciparum malaria to near elimination. Unfortunately, after the military coup, there was a collapse of the healthcare system, and malaria has come back with a vengeance. Another intervention, and sort of last mile intervention for malaria elimination, is to target the remaining risk groups, and the forest goers are a clear risk group. So the main malaria vector is Anopheles dirus, which lives deep in the forest, and forest goers have remained a risk group also in the pre-elimination state. And if you give prophylactic treatment to those village malaria workers, you can bring down falciparum malaria, but also Vivax malaria in those village malaria workers. This was a trial that our unit did with artemether-lumefantrine, which is not the ideal drug for this purpose, because lumefantrine has quite a short plasma half-life. But it did show that you could bring down quickly malaria in the region where it was tested in Cambodia. Now this intervention is being implemented using artesunate pyroneridine, which has a longer half-life in Cambodia and in Laos. And then we were all afraid with this increasing failure of artemisinin-based combination therapies, and a way to overcome that problem is to deploy triple artemisinin-based combination therapies, where you combine the artemisinin component not with a single partner drug, but with two matching partner drugs. And this is an example of artemether-lumefantrine plus amodiaquine. So lumefantrine and amodiaquine, desethyl amodiaquine, have quite well matching pharmacokinetic profiles, and they have counteracting resistance mechanisms. And this is one of the triple therapies that we have tested in the Greater Mekong subregion. Chanaki was very central in that, and are also now being trialed in Africa. They're quite well tolerated. They're very safe to give. And here in Asia, the triple combination is more efficacious than artemether-lumefantrine alone in this area with artemisinin resistance and also some decrease in lumefantrine efficacy. This triple combination is now made as a fixed dose combination by Fosun Pharma and being trialed in Thailand and African countries. And we hope that will become available in 2027 because we need this triple combination now for Africa, where artemisinin resistance has now also emerged in East Africa and is spreading there. So with these interventions, with this architecture, with this good collaboration between all the stakeholders, in the eastern part of the Greater Mekong subregion, elimination of falciparum malaria is now very, very close. In Cambodia, for instance, you know, the cradle of anti-malaria drug resistance, only a handful of cases in the last year. Also Laos and also Vietnam and also the eastern part of Thailand, really it's going towards elimination. However, as I said before, in Myanmar there's a big concern. It was going very well. Malaria was going down sharply, both falciparum and vivax malaria. But since the military coup, there was a collapse of the health system. The numbers we get out of Myanmar are not very reliable anymore. So the map you see there on the right-hand side is more red dark than denoted in the picture. A lot of that malaria we think is also artemisinin resistant, so that is a big concern going forward. So in conclusion, the Eastern GMS is approaching malaria elimination. Through this Global Fund RAI initiative, all the stakeholders working together. Really the cornerstone is this network of community health workers, village malaria workers for early diagnosis and treatment, supplemented with this endgame intervention. So the 137 approach, I didn't discuss that at all, but in the pre-elimination phase, index cases, they get case investigation if they are local cases or being imported. There is focus investigation, see if people in the perimeter of the index case or has the same risk profile as the index case also carry malaria parasites, and then focused interventions to treat those additional cases. It's called the 137 approach, comes out of China. China has eliminated malaria, where this approach was tested for the first time. It's also being used in Thailand, in Laos, in Cambodia, and in an adapted format also in Vietnam. Targeted MDA is done also at the moment in Cambodia, in Laos, can supplement this. Maybe it's even more effective if you combine that with the R21 matrix M falciparum malaria vaccine. We're doing a trial at the moment in the Bangladesh hill tracks to see whether that can be a good elimination tool. And then there are these targeted interventions for forest goers with chemoprophylaxis in forest goers. The big concern is Myanmar, where malaria has gone up sharply and it's very difficult to reach those populations. So, sorry, Kevin, I completely ignored Vivax malaria, but I'm sure you will make up for that in your talk. Thank you very much for your attention.
Thanks very much, Ed. And we will go straight into the next talk, where Kevin will indeed talk about Vivax malaria. So just to introduce, Professor Kevin Baird is a professor of malariology at the University of Oxford and he has been the director of the Oxford University Clinical Research Unit in Jakarta, Indonesia, since its founding in 2008. Kevin earned a PhD in medical zoology and parasitology at the Tulane University School of Public Health and Tropical Medicine at New Orleans, and has served for 22 years in the US Navy as a malaria specialist, with tours of duty in Washington, Indonesia, and the Philippines in Southeast Asia, Guyana and Peru in South America, and Ghana in West Africa. So over the duration of his 40 years in malaria research, Kevin has specialized in the malaria caused by Plasmodium vivax, including elements of prevention, control, diagnosis, treatment, epidemiology, and pathogenesis. Over to you, Kevin.
Thank you, Chanaki. And I also want to thank Trudie and her team at the Global Health Network for organizing this and really being able to pull in a truly global audience. So I'm very happy and delighted to be able to speak to such an audience as this one. I'm going to be speaking quite specialized about the research program that we run in Indonesia, hopefully to give you an idea of what an Asian malaria research activity looks and feels like, what we focus on and why. I'm going to be showing you a lot of data from the unit in Indonesia, and I just wanted to acknowledge this is the work of a great deal, large number of people. They are pictured here, and actually not included here are many partners and friends in the Ministry of Health and various universities, especially the University of Indonesia, and some others like the University of North Sumatra. Iqbal showed you this map. I've included the total numbers there from the Ministry of Health. They reported almost 500,000 cases. WHO estimated over 1 million cases. And the WHO estimate for fatalities in Indonesia is 2,000. And as Iqbal suggested, we think that's quite lowballed. So Indonesia has a very widespread and very varied malaria problem, from not being present at all, to being present as a little bit, to being present as a very heavy and serious problem, as you can see there in the eastern end of Indonesia. So the Oxford unit in Indonesia, we're embedded within the Faculty of Medicine at the University of Indonesia. The malaria program, of course, focuses on priorities of unique abilities. So we look for what we can do better than anybody else, or do it at all compared to other competing laboratories in the region and beyond. So we're focused on being a proving ground for the radical cure of vivax malaria. As has been mentioned by both Arjen and Iqbal, P. vivax will be the toughest to eliminate. There's the most compelling reason for that is that the radical cure of P. vivax, that is killing the latent liver stages that infect us and cause relapses, is technically complex. It's a very complex pharmacological problem. It's logistically difficult. Programs have great difficulty carrying it out to effect. And it's potentially dangerous because acetaminophenolines cause serious hemolytic toxicity in patients who are inadvertently dosed with these drugs. So we have access to a uniquely powerful clinical trial model for definitive assessments of radical cure efficacy. I'll be showing you that model in a minute. We also view ourselves as being able to offer a proving ground for malaria vaccines outside of Africa. We all know that the vaccines that are fielded in Africa are rightly aimed at very young African children infected by P. falciparum. This is where the mortality occurs, so of course that's where we aim our vaccines. But in Asia, we have a different problem. The mortality occurs in people of all demographic groups because there's low transmission and less strong naturally acquired immunity. So dangerous malaria is quite common in young children, in teenagers, people of middle age, and the elderly. Everybody is vulnerable to fatal malaria in the region. So the problem with low attack rates and vaccine trials is a very significant one, and we think we have a solution to that. Our strategic focus is on Papua. The map of malaria incidents should explain why that's so clear. 90% of Indonesia's reported cases come from Papua, the area you're seeing here. So Indonesia's struggle to eliminate malaria is the struggle with malaria in Papua. And it's a very, very tough problem. So as a research laboratory, this is where we need to be working effectively and engaging with our Indonesian partners in that battle. And that is exactly what we are aiming to do. One model that we use to do malaria interventions research is Indonesian soldiers. Now, the soldiers we work with are typically based on malaria-free areas of islands like Java or sometimes Sumatra. And they go for security duties in far eastern Indonesia, in Papua, where, of course, they're exposed to very high risk of malaria infection. And then they come home. So we have access to non-immune young men who go back to a malaria-free area, and they have the latent liver stages of the parasites in their livers. So when they relapse, we can treat them, and we can understand with great accuracy the efficacy of those treatments against those liver stages. Same story for vaccines. If we want to know how vaccines work in non-immune travelers, this is the ideal population. This is one example of a randomized controlled trial for radical cure of Plasmodium vivax. And what you're seeing on the right of the screen, the left of the screen there, is about 500 soldiers, actually right off the boat from Papua, where we greeted them and enrolled them as they relapsed with Plasmodium vivax, and approximately half of them did. So 50% of the soldiers in that picture have hypnozoites of P. vivax in their livers and are going to suffer an acute attack of Plasmodium vivax. And when we enroll them, we treat them. If we do not give an ataminoquinolin, primaquine or tafenoquine, what happens is what you see in the red lines in the graph on the right. Almost all of them then suffer yet another relapse. All right, very high attack rate without an ataminoquinolin intervention. The black lines are various radical cures where we did administer high-dose primaquine in these soldiers. And you can see that nonetheless, a lot of them relapsed. I mean, like 15% relapsed despite high-dose, directly supervised primaquine. And we wondered why. So we took those soldiers who relapsed, and we took those who didn't, and we did a case control analysis. And to make a long, complicated story very short here, we proved that treatment failure in those soldiers, again, in radical cure, was directly attributable in almost all cases to impaired CYP2D6 metabolism of that drug. So primaquine is a prodrug. It has to be metabolized to work. CYP2D6 enzyme does that metabolism, and it's highly variable naturally. So if people have impaired CYP2D6, they're at risk, serious risk of treatment failure against relapse by P. vivax. This is another randomized controlled trial we did where we looked at the combination of tafenoquine, that's the single dose radical cure from GSK, and we combined it with an ACT. You may know that tafenoquine is registered and proven to be efficacious when it's combined with chloroquine. We can't use chloroquine in Indonesia because P. vivax is resistant to that drug. So we have to combine it with an ACT. And that's what we did in this trial. And to our surprise, shock actually, you can see in the graphic there that tafenoquine failed to prevent relapse of P-Vivax when it was combined with dihydroartemisinin and piperacin. So with this model, we're able to conduct practice-defining features of radical cure because our model strips away the confounding by reinfection over months of follow-up. If we don't have to worry about reinfection, muddying our results, we get very clear answers, and that's what we do. We've also recently completed a malaria vaccine trial. We used Scenaria's irradiated sporozoite vaccines that uses an African strain of Plasmodium falciparum sporozoites that have either been attenuated by irradiation or by chloroquine suppression of perfectly healthy sporozoites. So that's PFSPZ vaccine, that's irradiated sporozoites. PFSPZ-CVAC, that's the one that uses chloroquine attenuation. And you can see we used the soldier model. We immunized them in Sumatra at their base over a period of 5 months. And then we followed them to the hyperendemic area of Papua. We stayed with them through their 10-month deployment to that area. And then we followed them back to their base in Sumatra, where we're able to observe every malaria case. You can see what happened here. It's 440 soldiers. We enrolled 350 over the months of the study. Hundreds and hundreds of cases of Plasmodium vivax and Plasmodium falciparum. Importantly, after they got home, where there's no malaria transmission, of course, PF cases stopped. But those P-Vivax cases just kept coming as if they were still in Papua, even though there were no malaria-carrying mosquitoes in that area. This is a very long-term, we integrated ourselves within this infantry battalion. Their health unit became part of our team. And this access is a privilege. It's one through managing the relationships properly with the military authorities of Indonesia. It's an exercise of trust, and we work with all the battalions and for months at a time, deeply embedded with them and developing relationships with them. Here's the results of that trial. The irradiated sporozoite trial vaccine, I should say, is on the left, and the chloroquine attenuated vaccines on the right. Essentially no difference between the two. The 24-week efficacy in both was around 50%, slightly better for the irradiated sporozoites. Now, if we look at the people who live in the communities where these soldiers were doing their duties, and we go to the clinics where they go with malaria, we were quite surprised to find an awful lot of malaria going on in the community and the people who live there, as much as in the soldiers in the forest and doing their security duties. What you can see here is from a population of 65,000 people, and you can see that every month there's over 3,000 cases of malaria in their clinics each month. So it now occurs to us that we can trial vaccines practically, small sample sizes, against both species of parasite and in all demographic groups. And that's what we intend to do. So this is the area where we did the malaria vaccine trial. You can see that we're in the northeastern corner of Indonesia here. Papua New Guinea is just to the right. Jayapura is the major city in that region, almost 500,000 people there. But these communities in the forest, you can see them as these, what look like small grids and cleared areas. That's where the folks in these communities live. And it's important to point out that the vector here, as Iqbal mentioned, are the punctulatus group mosquitoes. These mosquitoes hate the forest. That's not where they live. You clear out the forest and they move in. And that means the malaria transmission is occurring not in the forest where people might be working, but it's occurring in the villages where people are living. So children, women, men, everybody gets malaria at about the same rates. The API in these communities is about 500 per 1,000 residents per year. That's just a Google Earth zoom on what, all of these communities look like. You can see they're very well, highly organized, laid out in grids, people's homes. Yeah, it's all single family homes. And this is where these folks live. And it's ideal, frankly, for doing malaria studies. We have teamed up with our friends in the Ministry of Health on this effort to conduct malaria vaccines research in Papua as a priority for us and them. They've just completed this beautiful, enormous public health laboratory in Jayapura. And they've invited us to share spaces and join them in this laboratory. And that is what we intend to do. We have a discussion and a memorandum in progress right now. But very important, MOH is our key partner in this endeavor. So this is the envisioned roadmap of malaria vaccines research at that site. And we see it leading to, assuming we get decent results, leading to the licensure of vaccines available to Indonesians in Papua and everywhere else, hopefully by around 2032. These are trialing the Oxford R21 vaccine for P. falciparum. And that group also has formulated an RVX21 vaccine for Plasmodium vivax malaria. And we're very excited to be able to look at that vaccine for the first real world look at it in these communities. We'll continue the soldier model to develop vaccines that work for travelers as well. Indonesia has a lot of travelers, including soldiers. And that's our plan, and that's our hope. Thank you for listening.
Thanks very much, Kevin. We're a little bit over time, so let's move very quickly into the next talk. And our speaker is Dr. Mary Chambers, who is a public and community engagement specialist. She has led the development of the Public and Community Engagement Program for the Oxford University Clinical Research Unit in Vietnam, Nepal, and Indonesia. Mary's personal interests lie in using participatory methods to amplify community voices and bring them into conversations about biomedical research. She has recently published on the ethics of participatory methods, vaccine uptake in hard-to-reach communities, and on sociocultural aspects of COVID-19. She has a PhD in medical entomology from the University of Cambridge and has over 25 years of experience in Southeast Asia. Over to you, Mary.
Thank you for that introduction, Chanaki. Very pleased to be here with such a wide audience. So my presentation today is about community engagement in the context of malaria research in Southeast Asia. And the examples that I'm giving are coming from both MORU, where Arjen is based, and from OUCRU, as described by the previous speakers. So the goals of community engagement in malaria research are very much like the goals in engagement in other research settings. And these would include working with communities to build trust, to strengthen relationships between researchers, stakeholders, and community members. It involves creating platforms and opportunities for dialogues with those groups. Community engagement can help researchers better understand a trial community's attitudes towards research and their wider health priorities. And it can specifically help bring in underserved groups, such as the forest goers that Arjen spoke about, and those who are less heard into these conversations. So community engagement can be included at all stages of a research study. And in the next few slides, I'm just going to give some examples of engagement conducted in Southeast Asia. So prior to a study starting, community engagement is essential in helping us to identify the wider group of people who are associated with a study context. So this is more than just the study subjects who will be recruited. Community engagement can help us to identify the other people who may be instrumental in enabling a study to happen or giving permission for a community's involvement. Engagement can also be used to help gather feedback on the acceptability of a proposed study and feedback on study designs. So examples of pre-study engagement include informal meetings with key stakeholders. Sometimes these are called gatekeepers because it's necessary to have their support before approaching a community. These may be village leaders, traditional healers, or local government officials. Or engagement might be through more formal advisory groups. And community advisory groups, CAGs or CABs, are increasingly common for institutes that are conducting community-based research. And these groups consist of volunteers from the local community that's involved in a study. And they will meet regularly with the research team. Although not chosen by the community to represent them, they can share local perspectives and knowledge. So this slide shows examples of community advisory groups from MORU. And the first, the picture on the left, is the TCAB. This is a group from the Burmese borderland communities who live on the Thai-Myanmar border. And the World Malaria Research Unit, SMRU, has been working with these migrant populations for over 35 years. So the TCAB was set up in 2012 to enable the community, this very specific community, to give input into research proposals and to advise on how they could be made more acceptable to the borderland communities. And the second example is of a youth advisory group set up in Simpang province of Cambodia. This is a group of 16 to 22-year-old local students. They learn about research, they discuss their experience of malaria and other health issues, and talk about the health priorities of this increasingly young population. And this is an example of how feedback from a CAG in Laos in the context of an MDA study has supported the research. So on the left, you can see an illustrative poster that was designed by the study team to try and illustrate how malaria elimination is possible. However, when discussed with the community members, they gave feedback that the poster was very hard to understand and it should be drawn more realistically, illustrating the Laotian context. So on the right is the final poster with input from the community. So the second phase of a study is the study startup, and the community engagement is very important to support recruitment. We think about the consent, this consent process, and so there's intrinsic goals with trying to make our studies more ethical, and then also instrumental. We want the community to accept the study and to support recruitment. And so Kevin spoke about the malaria vaccine trials that OUCRU Indonesia and the Ministry of Health have been running using the armed force soldiers as study participants. And this group can be considered as vulnerable to coercion. So if a superior tells them to be involved in a study, they have little choice. So to help address this issue, we worked very closely with the Armed Forces partners to make a motion picture video which explained the study and the requirements that were being asked of the participants. The soldiers were able to watch this film in advance and ask questions before being formally asked to consent or not. So the actual film is about 7 minutes long and it has audio. I'm going to show you a very short clip, but I think Louis has put or will put a link to the full film in the chat. So Louis, can you just play that very short film? So this is very sped up. Explains how participants would be screened, how they're deployed from their home base, Sumatra, the control, and then the two vaccine, they're not shooting each other, the two different vaccines It shows them being brought home to their home base in Sumatra, coming off the boat, as Kevin showed, screening with a study doctor. You can see one soldier's febrile, and then the results that would be expected. Thank you. So using that video, the research team were able to explain quite a complex study design and answer questions from this group of recruits before the formal consent process was done. So another example of the importance of engagement at the start of a study comes from the SLIM study, which was led by Kevin Kablinski on the island of Sumba in eastern Indonesia. This study involved injecting livestock with ivermectin and observing the effect on blood feeding mosquitoes. In the very first study site, we initially set up the livestock nets in an open area in the village. However, after some hours, realized the villagers were quite upset because the nets were too close to an area of land that was considered as sacred. So after that incident, we were careful to hold a more public. We had permission, obviously, from the village leaders and the livestock owners, but we hadn't included the wider public. But after that incident, we held public meetings in the villages, including not just the study participants, but other people from the communities, to discuss how the study should be run in their location. And then thirdly, once a study has started, the work is not finished. Ongoing engagement is really important to ensure that the research team are aware of community concerns and able to respond to them quickly. And this may be very important if retention in the study is important. So an example comes from the MORU MDA malaria trials that Arjen spoke about. These have been run in Cambodia and the greater Mekong region. So in order for malaria elimination, the whole community needs to take part in the study, and they need to be treated at regular 3-month intervals. So getting this ongoing community acceptance in these trials can be challenging because there are sometimes side effects from the drugs, and people might also not see the need to keep taking drugs when they aren't sick. In response to this challenge, the MORU community engagement group, led by Professor Pekyong Che, developed a theatre program which toured around the around the rural villages in Cambodia. And the aims of this drama were to raise awareness about malaria prevention, about using nets, but also to introduce the study and improve recruitment and retention in these MDA trials. And over a 4-year period, the drama was taken to 55 villages and reached over 40,000 community members. And again, Louis is going to put a link in the chat to a really excellent film of this drama project. So finally, at the end of a study, engagement is just as important. So no one would disagree that it's very important for researchers to publish results and disseminate findings amongst the scientific community. But all too often, the results are not shared with participants and the communities that have enabled the study to take place. Dissemination meetings are really important to share results, but also to gather feedback on what the community thought about the study conduct. And it's been more than once we've met community members who've had a bad experience with a previous research group, as one person told us on the recent study in Sumba. They took our blood and then they left. We never heard from them again. We don't know what they did with our blood. Maybe they sold it. That sort of experience can be avoided by intentionally building in engagement at the end of all clinical studies. So the researchers in the SLIM study, this is the ivermectin in livestock study, held dissemination meetings in the study villages, but they also held a meeting with the local stakeholders involving village leaders, local vets, local government. And they shared the preliminary results. They weren't the published results, they were preliminary results, and asked for feedback on priorities for studies in the future. And the community leaders said that they were proud to have contributed and they would be willing to be involved with other studies in the future. And then finally, wider public engagement is also important. So malaria in Southeast Asia is often hidden amongst the poorest and the most isolated communities. And many urban Asians are unaware of the local burden of malaria that's on their doorstep. So using photo exhibitions, press and social media, we're also trying to raise awareness of the burden of malaria to the wider public. And one such example is this Malaria World online exhibition that's here on the Global Health Network Malaria Hub. And there is a QR code there for quick access. And then finally, I end my talk with this quote from the Director General of the WHO in the recent guidance on best practice for clinical trials. And he says, community engagement is not just a part of global health research, it is the heart and soul. And from our perspective, our malaria research is stronger because of the partnerships with communities. I'm just going to end with these acknowledgements because I've presented a number of projects from many different people. So thank you.
Thanks very much, Mary. So we have about a little more than 15 minutes left for Q&A. So let's get started right away. And if I can ask all the panelists to switch their cameras on. So for the first questions, we have a few questions in the chat. Some of them have been answered. We also had some questions which participants posed during registration. So I thought we could start off with one of those questions. And this is, so it's open to any of the panelists. So the question is, what is the disconnect and challenges between research and community engagement activities and operational programs? Mary, you might want to take it first, or if Arjen would like to take the question.
Mary, you go first.
So I think that operational programs also need to do community engagement. I think that whether it's a public health intervention or whether it's a research study, that the acceptance and partnership with community is also essential. So I'm not sure if that's answering the question, but that's a quick answer. Arjen?
Yeah, maybe to add, so I think it requires active engagement of the research community with the malaria control programs. And there are several structures in place. So in Asia, we have APLMA, who really actively engage with programs and organize meetings to disseminate research findings. In the Greater Mekong subregion, we have this close collaboration in the regional steering committee, where also all different stakeholders are together, including the academics. So that is also a very good way to communicate the latest research findings with the implementation programs.
Thanks very much. And just taking one more question from this list that we were sent ahead of time. So I think it's very relevant. What long-term strategies are being considered to ensure sustainable malaria control in refugee settings, especially in light of ongoing conflicts and displacement? Arjen, I think this would be a question for you. If we could just...
Yeah. Well, it's a very difficult one. So our experience in Myanmar shows that they were doing so well. They had this beautiful network of integrated community malaria workers. Malaria was going down. But once you don't have the political stability anymore, you can have beautiful interventions, but you cannot implement them anymore. So that is really a problem. The refugee camps, we know from the past, from the Myanmar border, but also other countries. There, usually the NGOs, the civil society organizations, have been very important to set up healthcare. Sustainability of that is often dependent on donor money. And we all know what is happening at the moment in the world with more nationalism, less money for foreign aid, and so that is worrying, and I hope we can overcome those problems.
Thanks, Arjen. So let's go to the Q&A session, which attendees have posted now. So the first question is regarding vaccines. Kevin, would you like to take this one? So it's about the concern about pregnant mothers, whether they'd be eligible to get the vaccine since they're vulnerable. And if yes, are we supposed to continue giving them Fansida?
That's a really tough question. I actually am not that familiar with what they're doing with R21 and RTSS in Africa. Are pregnant women getting those vaccines in Africa?
It's for children in Africa.
But not pregnant women.
No.
Yeah. It's a really tough point. But I suppose there's a reluctance to vaccinate pregnant women until there's data that suggests that women who were vaccinated not knowing they were pregnant, we can study how their pregnancies turned out. So that takes time.
And I think there's another question for you. You were typing an answer. It's whether e-consent was taken from the soldiers.
Yeah, I was just typing my answer. No, we used direct in-person consent process. It was actually a quite involved hour-long process for each soldier. It was done in the presence of a peer and with wet signature. We did not digitalize that in any way.
Thanks, Kevin. So there's a question from Mary. What should we do to engage communities in high malaria endemic areas who will become our research population, but perceive that malaria cannot be eliminated from their land and have come to see the disease as a familiar part of their lives?
Thank you. I think you can share success stories from other places. I think it's also important to highlight to them what the burden of malaria, so they may be living with it, but what the clinical burden is on fatigue, on anemia, on days lost from work, on days lost from school. And this might be by showing results from other places and just sort of showing them what the potential is for clearing the disease and how much healthier the whole community will be. Also stories. I think everybody we've asked in these areas actually have a story of somebody who has had it seriously, of a child who's died. And I think by sharing those stories, again, it can raise the severity and the seriousness of the disease.
Iqbal, you had answered a few questions online, but maybe this is one for you. I would like to ask how to overcome malaria vector resistance to insecticides in the malaria elimination program.
Thank you. That's a very good question. So if you know that how we attacking the mosquitoes, so we can attack the mosquito when they are in aquatic habitat, when they are still live as a larva or an adult mosquito. So one way of reducing the mosquitoes suppression is applying the larva source-based management. For example, it's like the clearing the habitat, environment modification, manipulation, and also the community involved in the clearing the habitat. Let's say, for example, the opening the coverage of the rice field, for example. So there's evidence it's a massive actually, and some example has been conducted in I think the early 2030 in Indonesia by using the spatial sanitation. Yeah, that's all my question tonight.
Thanks, Iqbal.
Yeah.
A question for Arjen. Is ALAQ better than multiple first-line treatment?
So that is relevant for Africa at the moment, where artemisinin resistance has arrived, and the WHO has now written a regional approach to contain the problems, recommending multiple first-line treatments, so that in a certain area you have different first-line treatments, still ACTs, but different ACTs available, so that the parasite populations see different partner drugs over time as a strategy to not develop resistance to the partner drugs. That can be done, but is quite difficult to implement, and some of these ACTs are quite expensive. The triple ACT, artemether, lumefantrine, and amodiaquine, with these counteracting resistance mechanisms between lumefantrine and amodiaquine, that fixed dose triple will be just a little bit more expensive than AL, easy to implement. And if you do mathematical modeling on the impacts on resistance development, it's very efficacious. So probably better and easier to implement than multiple first-line treatments. But it's not being marketed yet. So at the moment, we have to do this multiple first-line treatment approach.
Thanks. Kevin, a question for you, since you spoke about vaccines. Is Asia also among the regions that is using RTSS, since the research on the vaccine was completed and the efficacy was approved by the WHO?
Who's that for?
For you, Kevin, or anyone who'd like to take the question.
Well, we are more interested in the R21 than RTSS, primarily because the government of the Ministry of Health looked at RTSS and made the decision without trialing it here that it was not for them. So they were not interested in RTSS. They are interested in R21. So that's the vaccine that we will move forward with, because the MOH wants to look at that vaccine in Indonesians.
That's good. And maybe a question for Iqbal. So the question is, why have children accounted for most malaria deaths in Africa, but malaria deaths are affected in all populations of age in the Southeast Asia region? Is it due to travel or immigration?
Thank you. That's a very good question as well. So I think because there are different characteristics of the transmission setting especially in Africa and here, the factors in Africa is a very efficient. The Anopheles gambiae is, I think, is the highest efficient of transmitting malaria compared to the Anopheles factors in Asia, which are less efficient. So I think one of the main reasons why we found the highest proportion of the severe malaria death among the children in Africa compared to the age group or compared to other group in the region. So I think that's my response.
Yeah, I can maybe add to that. So in those high transmission settings in sub-Saharan Africa, a child is bitten every day or every week by an infected Anopheles mosquito, compared to once a year in our region here in Asia. And because of this constant exposure to the Plasmodium parasite, Falciparum in Africa, they develop partial immunity against the disease in the first 5 years of their life. It's called premunition. So severe malaria and symptomatic malaria is really a pediatric disease in these areas. Whereas older children and adults, they can still be asymptomatic carriers, but don't develop severe disease anymore.
Thanks, Arjen and Iqbal. So just on the topic of mosquitoes, another question for anyone to answer. So I've heard for quite a while that gene-drive technology might be a hero when it comes to eliminating mosquito-borne diseases. Would you give some insight or any alternative approaches? If anybody wants to speak on gene-drive.
That's a tough one. I don't want to be a Luddite, but I'm somewhat skeptical, and mostly because, you know, there's trust issues with genetically modified organisms in the natural environment. I mean, there's some countries that won't allow genetically modified foods, right? Because the population fears genetically modified living things. And mosquitoes certainly would provoke that fear, whether it's justified or not. I know that some recent efforts to roll out genetically modified mosquito anophelins in a small African country, an island off the west coast. I'm blocking on the name of it. A research group tried to release, tried to conduct an experiment where they released genetically modified anophelins. They wanted to measure the impact on local populations of mosquitoes and, of course, malaria. And the community met, and there's a very interesting article in the New York Times on this, that community met and they came up with a very wise decision, in my opinion. They decided that they did not have the knowledge to know if this was safe or not safe. So they declined permission.
Thanks, Kevin. So I'm just going to go back to the questions that were directed by attendees when they were registering. And this, I think, is a question for Mary, not really applicable to Southeast Asia, but more to Africa, but still a very important question. How would you engage with pregnant women very early on in their pregnancy so that they can benefit from protection from anemia due to malaria, especially in the first trimester?
So I think it's really important to have a specific approach for every single community group, and not have a one-size-fits-all engagement approach, and also to meet people, not to ask people to do extra activities. So I would start by working with people that they already trust, working with within the neonatal care, the maternal care program, or whatever it is in the country that you're in, and then maybe meeting people when they're coming in for their pregnancy health checks, so that you're not trying to you're not asking people to do something extra, but you're also meeting them in a trusted and safe space, and then having very open discussions. What do they worry about, and can you answer those questions? Can you bring in an expert, and have a doctor or a midwife or somebody or a scientist there who can help answer their questions? So I would meet them where they're at and have very open conversations.
Thanks, Mary. So we'll take a couple more questions and just extend another 5 minutes. So a question for Arjen. So this is in the Q&A box. With regard to community-based test and treat, did the model evolve in phases, or was the transition quite seamless? I'm very interested to hear how this model evolved to enable other health applications and how easy was it for this model to be adopted and embedded?
Yes, so the development of the village malaria worker networks in the GMS goes back 25 years and started on the Thai-Myanmar border, but then also in Cambodia, in Myanmar very early on, where lay people were trained and incentivized to diagnose with a rapid diagnostic test and provide anti-malarial treatment. In some areas, we're also involved in the handing out of bed nets, and also importantly in the reporting of cases, so that we got good surveillance data. It requires a lot of training, a lot of supervision, a lot of support. But it was rolled out quite rapidly in the countries here. The concept, by the way, is very old, and also in Africa, in Ujamaa period in Tanzania and the Nyerere, it was already implemented to have community health workers for healthcare. So it is a package that they can deliver, but which requires good organization, good engagement, and good ways to incentivize those malaria workers. I hope that answers a bit the question.
Thanks, Arjen. Maybe just a final question, if I can ask it, and this is directed to Arjen and anybody on the panel. And Arjen specifically, so you mentioned the Global Fund Regional Artemisinin Resistance Initiative and how it's played a big part in providing the necessary funding for malaria elimination activities in the region. Would that fund be continued in the next 10 years or until countries reach elimination? Or are the countries expected to seek different avenues for funding? What do we know about that?
Well, the future of the global funds, with everything that's going on in the United States at the moment, and the United States is the biggest country donor for the global fund, although many countries contribute, is uncertain at the moment, so it's difficult to answer that. For the GMS, I'm quite positive for the eastern parts, where malaria is really almost gone now, where the amount of money that is needed to do the final part is relatively limited. I'm much more worried about Africa, because a year ago there were serious discussions started to implement these RAI-type structures also for African regions. That is now really under threat with the funding cuts that are being made.
Thanks very much, Arjen. And again, a question to Mary in this same light. Does this affect community engagement work as well? Is it very dependent on international funding, or are there funding avenues that are available for smaller projects which don't necessarily involve a big clinical trial?
So generally, funding for engagement would be part of the trial, the wider trial funding. And we try to work with trials, the study staff right at the proposal level, so that it's part of the initial funding, the initial budget, and very embedded. A few funders, such as NIHR, will give small amounts of money for you to do some initial community engagement with to try and understand health priorities, try and understand acceptability of a study prior to even writing that proposal. But that's there's only a few funders who will do that. So I think community engagement funding is going to be affected in the same way as research funding.
Thanks very much, Mary. And we have come to the end of the webinar, so I think I don't see any questions that we haven't answered in the chat. There are lots of questions remaining to be answered. These are questions that we received when the during registration. So I'd like to just thank all the participants for joining. We've had over 200 participants, so thank you very much for joining and for all your questions. And thanks very much to the panel. And again, as I mentioned, we have received many comments, so we'll gather all of these and put them together, and we'll ask the panel to respond to them in writing. And the recording of this session, along with all the additional materials, will be shared. The link, I think it's going to be posted right now. And once again, thanks very much to all the panelists and for all your participation. And we'll now close the session.
Thanks very much. Great session.